today's CalMap webinar on suicide prevention and how we apply suicide prevention principles and safety planning in primary care. Just a few quick announcements before we get started today. While these webinars provide a great introduction to a lot of the basic skills that we all need to provide mental health care in primary care, we also have individualized help available. So anytime during normal business hours, please do call us. There's the 800 number there on the slide, 800-253-2103, or you can scan the QR code, go to our website, and place a consult request online. You can talk with one of our child and adolescent psychiatrists for just real-time advice on how you help your patients with mental health concerns. You can also consult with our care coordinators to help find resources in your area for your patients, which is great. We also have some psychologists here who are available with help for specialized concerns like eating disorders, autism, early childhood mental health issues, and so many more. Next slide, please. So we've got a lot of other events coming up on our continuing education calendar. Our advanced echo is going to be starting up this coming week. That'll be happening on Wednesdays. Please check the announcements that are coming through the listserv for more information. Our next talk will be on trauma and PTSD. Our next webinars that will be coming up will be addressing racial trauma and discrimination, as well as disruptive behavior disorders. So hope to see you here for these. We do also have our school echo and our therapeutic skills echoes going on as well. You can see a little bit more information there on the screen. Feel free to scan this QR code to find out more information about all our different educational offerings here at CalMap, and we hope to see you at some of these future events. Next slide, please. A quick word on our disclosures. We don't have any financial conflicts of interest to disclose. This is a quick word on our funders, both from the federal and the state level. And with that, I'd like to introduce our wonderful speakers for today. Shelly Nakaishi is a certified pediatric nurse practitioner at UCSF Benioff Children's Hospital, Oakland. She provides outpatient psychiatric medication evaluation and medication management to children ages 3 to 21 in psychiatry and also at the Castlemont School-Based Mental Health Clinic. She also provides psychiatry consultation educational trainings here at the CalMap program, including many talks here on suicide assessment and prevention, as well as some other topics as well. In addition, Shelly has helped to co-create and teach UCSF School of Nursing course on treating pediatric mental health conditions in primary care settings. Dr. Hohui Eileen Wang is a clinical assistant professor in the Division of Child and Adolescent Psychiatry at UCSF. She provides outpatient care at UCSF Benioff Children's Hospital, Oakland, and also in the West Bay in San Francisco at the Pritzker Building. She leads a teaching clinic and works with trainees at UCSF Benioff Children's Hospital, Oakland. She also staffs our CalMap portal, so you can talk with either of these wonderful consultants here when you call our line. She's also an integral part of the continuing medical education team, helping to design and develop this curriculum. Her research interests include medical education, PTSD, sleep, and the gut-brain axis. As usual, we will be reserving the last 10 to 15 minutes or so for audience Q&A. So if questions come up for our speakers, please do share them in the Q&A portion. And with that, I'll hand the virtual mic over to Shelly and Eileen.
Thanks, Dr. Joanne. This is a really difficult subject to talk about. And it brings up a lot of strong emotions around, we have our own experiences with suicide and working with our clients and patients. It brings up a lot. So we just want to make sure we offer this space. And also, as Dr. Joanne mentioned, reaching out to CalMap for consultation and support. Not in a crisis situation, but as we walk through, if there's different pieces of this that we can consult on. And we really want to emphasize that, Eileen and I have been working through how to present this topic in many different ways. And we also recognize that every setting has its own unique way of having crisis procedures. And so we just want to make sure that this is a broad view, but it's to provide questions and ideas and to bring it back to your own clinic procedures with your own leadership team. Next slide. So basically, we are going to walk through the new AAP blueprint in a role play way to go through about a workflow on how to do suicide screening and assessments. And so that's pretty much our objectives, is to kind of talk it through so you see it in action and go through all the different steps of screening to the suicide assessment to actually doing some lethal means, restriction counseling and safety planning. Next slide. But first, we want to do a check-in, a flight check, because before you start to do this suicide screening and assessments, first we need to check in with ourselves and how we're doing. But also we need to check in with our whole clinic staff to make sure that they're ready to do this. Whenever you start a new procedures, we want to make sure we have a landing procedure before we take off. So that's kind of just, the moment to check in. I know that maybe some of our clinics may not have all the procedures set up. So then a lot comes on us as providers to make sure we set ourselves up. So if we experience someone who's suicidal in our clinic, we have all our resources to help us set them up for the right treatment. Next slide. So part of this is, how do we check in with ourselves? And that's making sure we're checking in with ourselves, making sure we understand our biases, our thoughts, our reactions when we do these types of assessments that are, really stressful. And part of why I started doing these trainings is because in my setting, I wasn't taught and residency and really doing suicide assessments. But now through DBT training and doing these trainings, I feel much stronger, and I'm aware how I am able to communicate and do these assessments much more effectively. So it's working from my own standpoint first. It's also knowing that we're working in a team and making sure there's a team-based care in place. That makes me feel safe as a provider. And then, of course, always checking in with ourselves and making sure we have our own self-care. The next part is, how do we check in and make sure we're being as thoughtful as possible and trauma informed with our patients and clients? How do we approach it in a very non-judgmental, culture responsive way, when we can, offering choices such as, like, would you like me to share this with your parent, or do you want to tell them? So when we can, offering choices. Also, languaging can be a big part of the approach, making sure we don't say the words committed suicide, but we use died by suicide, or that was just a suicide gesture. We want to avoid saying that and make sure we say suicide attempt. The other things to think about when you're rolling out these clinic procedures is, how do we involve security and police, and how do we make it as seamless and safe as possible? Next slide.
Thank you, Shelly. And while holding trauma-informed principles in mind, we're going to review a few things about the AAP blueprint. So as you all know, PCP plays an important role in suicide prevention. 80% of individuals who die by suicide had seen a PCP in the previous year. Suicide is the fifth leading cause of death for young children, aged 5 to 9, and it jumped up to the second cause for older teens and young adults from 10 to 24 years old. So it really is a crisis situation for children and teenagers. The blueprint for youth suicide prevention was relatively new. It was released in 2022, and it was a collaborative effort that involved AAP, American Foundation for Suicide Prevention, and NIMH, with community stakeholders to develop a three-tier pathway that is practical for and hopefully realistic for PCP to adapt to. It also has a website that provides guidelines, rating scales, and toolkits. So the reality is, none of us can do this work alone. It takes an entire team, which includes nursing staff, medical providers, social workers, case managers, admin, even security, and other partners like the county mobile crisis team, and even consultant like us at CalMap. It will be really helpful to involve leadership, to develop your clinic workflow if there is not a workflow in place that includes all stakeholders, and also including regular medical provider training, staff training, creating referral pathways, creating resources and flyers for admin staff, adolescents, and families, and also include post-vention support plans. You can see from the slide that it kind of go over the crisis procedures and what the clinic workflow looks like and what admin staff can do to help us obtaining PHQ-9 and ASQ separately, because they're not necessarily targeting or detecting the same thing. PHQ-9 is for depression, while ASQ is separately for suicide prevention and for suicide screening, and what to do when the ASQ is positive. So one thing that I learned myself is that it's really important, however often overlooked, that ASQ has to be done and interpreted during the same appointment. If the result is positive, we wouldn't have to proceed with the brief safety assessment and determine the disposition based on the information gathered. And a common scenario is the MA might have given the teenager the ASQ, and then no one really follow up with it, so that the ASQ result was positive and it was entered into the chart, but there was no relevant steps taken during the same appointment, including either it's a safety assessment or creating a safety plan or involving the caregiver. Disposition and the actions can be different based on the patient's risk level. After you complete the safety assessment, you can stratify the patient's risk based on the information that you gathered into low risk, moderate risk, and acute cases, acute severe cases. And the interventions will slightly differ. For mild cases, it's most important to consider routine mental health referral, potentially treating underlying psychiatric disorders, follow up within a month regularly until suicide is no longer an active problem, and also providing resources, phone numbers, so that they can call. The phone numbers will include numbers like 988, the crisis text line, and poison control. And for moderate cases, which will be the case that we will be role playing today, we'll talk more about what it looks like during our role play. And for acute cases, it will be involving caregiver and therapist right away, starting one-on-one monitoring of the patient, and depending on your clinic workflow, possibly calling security or mobile crisis team or even 911 for a detailed assessment. If we have time after today's role play, we do have a few slides reviewing what happens to these high-risk patients after they leave your office. If we do run out of time, we will share our slides so they can review them. They're at the bottom of the slide deck. So when it feels like we need an hour for this, for the suicide screening and assessment, the reality is each appointment is only 15 to 20 minutes long. So how do we do this? This includes clear, practical procedures and a team-based care to ensure every step is run smoothly. It is helpful to have your clinic's technology tools, such as using the medical record systems reminder flags, using embedded smart phrases, developing smart phrases and templates. They can really help you save time during the appointment. Additionally, handouts and flyers will also make it a lot easier to provide all important information to support teenagers and families when they're identified at risk for suicide. And finally, call us at CalMap for a non-emergent case. We're happy to work with you to think through the patient together if you're not sure what to do. Another thing I wanted to say is you're already an expert in identifying the problem, the target problem, and then solving the target problem. It is the same strategy we apply for suicide prevention. You can use the ASQ or other screeners like CSSRS, and then combine information you gathered from all cards surrounding suicide as a target problem to complete the brief suicide safety assessment. And also wanted to identify that this is truly hard work because we're holding so many pieces at the same time in a relatively short period of time. We're also thinking about the patient's privacy. However, at the same time, we also need to think about when to break that confidentiality very mindfully if the patient is suicidal and needs caregivers' help. We also want to be gentle and thorough, but we also have to cover so many questions quickly so that we can make sure that we provide patients with a safety plan and a safe disposition plan.
What this slide kind of shows that, you know, when someone has suicidal ideation, it's dynamic. The severity levels can go up and down over time. And we know, you know, suicide is very complex and dynamic, and there's many things that can contribute to the risk of society, not just depression. So, you know, the AAP blueprint really kind of emphasized you can't just screen if someone is depressed. We should be screening at least, you know, once a year in a well-child visit. And if they are come in with a mental health concern, we do a clinical risk assessment as well. And then, you know, the reason why, as Eileen was saying, our target problem is suicidal ideation, and we can determine the severity is because if it's, you know, mild, we want to reduce unnecessary harm or time if it's mild. But if it's more acute and severe, then that's when that helps us determine should they or should they not go to the hospital for a further evaluation. So, you know, and maybe in the old days we would ask and then we just send them directly to the emergency room if there was a positive suicidal ideation. But now I think the AAP is really asking primary care providers to do a thorough like check-in to see how severe and is it necessary? Can we set them up with other services in primary care and have our more frequent check-in with them before going to the hospital and for hospitalization. Next slide. I think this is
So we're going to go over ASQ scoring and quickly before we jump into the role play. And this is what the questionnaire looks like. There are 5 questions in total, and you'll go over the first 4 questions. If the patient answered no to all 4 questions, then you're done with a screener. In a different scenario, if the patient does answer yes to any of the questions from number 1 to 4, then you will proceed to number 5 and asking the question about, are you having thoughts of killing yourself right now, which is to determine the acuity of their suicidality. And if it's yes, then we'll go ahead and complete brief suicide assessment and also consider that this patient is at high risk. If the patient answer yes, and then you complete a suicide safety assessment, it is also possible with all of the protective factors that the patient report, you may kind of downgrade the patient to moderate risk or low risk. Then you can proceed with appropriate different action steps. And then this slide is for brief suicide safety assessment. This is to follow the screener. And if the screener is positive, which means that the patient answered yes to any of the questions, then you will proceed with the safety assessment. There are a few principles to hold in mind. First, praise patients and really give them a lot of praises and rewards if they share their scary thoughts of wanting to die, wanting to kill themselves to us, because it can be very scary for teenagers to share that. And then also assess the patient, like we mentioned earlier, using old carts to really get a good history of their suicidality, including past and current suicide history, and also holding this in mind to interview patients and caregivers separately, but also at the end together to make sure that everyone is on the same page in terms of the plan. And then finally, provide suicide resources, referrals, and also the completed safety plan to all parties, including patients and their caregivers, if possible, also involving their therapist to make sure the safety plan is updated. And then this is the workflow example of what this brief suicide safety assessment will look like in a clinic setting. The assessment is ideally broken into 2 parts, as I mentioned earlier, that first with the teen, second with the caregiver, and finally together. For the teen assessment, it should be done alone because a lot of times teen can withhold information when the caregivers is around, and they wouldn't be able to share every kind of piece of their thoughts and especially history. and then focusing on quality questions surrounding the target problem, which is suicide. So past and current suicide history, plans, intensity, frequency, any other self-harming behaviors, even if they're non-suicidal behaviors. And then based on the result of the safety assessment, if you feel the patient is at moderate or high risk, then proceed with lethal means counseling, making sure that there's no weapons, medications, or other harmful objects are in the house or they're secured. And then move on to discuss a patient-specific safety plan. Based on each teenager's family and living situation, we can invite caregiver to join in for the lethal means counseling part and safety planning part. For caregivers, you would either do it alone or with the patients, depends on their individual situation. And first, we have found this being helpful for our practice, which is kind of checking in first with the caregiver about their suicide awareness. And that would include their general awareness and understanding or any existing concerns for their teenagers' suicidality, and also about their own feelings. A lot of times, caregivers can be afraid, in denial, or even be angry. Sometimes they have family history of suicide, so those are very helpful to kind of get to understand first before we move on and break the news to them. And then again, for lethal means counseling and the safety plan, you can first do it partially with the teenager and also separately get further information from the caregiver and then involve the both parties to conclude our plans for lethal means counseling and for safety plan. So we're going to move on to the role play. There are 4 chapters of this play, and first we're going to introduce our roles. So we have, thank you, Joanne, for offering to play the grandmom, and I will be the teenager, while Shelly being the health provider. The patient is a 17-year-old non-binary teenager, now a senior, has a history of anxiety and depression, has been on SSRIs, and currently lives with grandmother. The 4 parts of the role play will be focusing on first, use and interpret ASQ, the suicide screening, and second, conduct a safety assessment. Third, complete a safety plan and lethal means counseling, and then finally, deliver a treatment plan to all parties. We're gonna get started.
Hi, Eileen. I'm Shelly Nakaishi, your nurse practitioner. It's really nice to see you again.
Hey, it's nice seeing you too.
I want you to know that we're going to be talking privately, so everything that we talk about stays between us. There are only 2 exceptions to that. One is if you give me permission. The other is if I'm worried about your safety or someone else's safety. In that case, I may need to talk to other professionals and people in your life to help keep you and them safe. I always will check in with you first if I need to tell someone something, and we'll talk about how we're going to do this. Do you have any questions about that?
Nope.
Okay, one of the things I ask all teenagers about regularly is about safety and suicide, because sometimes when things are hard in life, people can have feelings of wanting to die. So I'm going to go over a few questions. I know it can be difficult to talk about these things, and it's also really important that we ask, and we find ways to help you keep safe if needed. So the first question is, in the past few weeks, have you wished you were dead?
Not right now, but maybe a few weeks ago. Ever since my girlfriend said she's breaking up with me, I've just been feeling sad and crying.
I'm so sorry to hear that. Breakups can be really, really painful. In the past few weeks, have you felt that you and your family would be better off if you were dead?
Yeah, last week maybe.
Okay, in the past week, have you thought about killing yourself?
No, not this week or last week, but I have thought about taking Benadryl in the bathroom's medicine cabinet.
And when did that happen?
I don't know, I think a couple weeks ago.
Okay. And then have you ever tried to kill yourself?
No.
Are you having thoughts about killing yourself right now?
No, but a couple weeks ago, I know grandmom has Benadryl in her cabinet, and I have thought that if I take some or take enough, then I would just go to sleep and not wake up. Not now though, not anymore.
Okay. And have you done anything, started to do anything, prepared to do anything to end your life?
Maybe in the past when I was really sad, there's one time that I couldn't fall asleep and then I took 4 or 5 of the Benadryl pills.
Okay, thank you for sharing. I know this is really hard. And it sounds like you've been dealing with a lot of stress and pain. When you did take the Benadryl, did you take it because you wanted to die?
Um, I was just so tired and I just wanted a good night of sleep, but also part of me was kind of like, I want to end this so I don't have to wake up and think of my ex again. It's been just been hard and I don't know when I can be done with this, who I can talk to. I know this will freak my grandmom out, so I just keep telling her that I'm fine.
Thank you for telling me about all this stress you've been having, and about not wanting to wake up. I know, I understand you're not using any drugs or alcohol or vaping, and that you've been keeping up with your schoolwork and still playing soccer. It does sound like sleep and depression have been a challenge for you last month. And you've been so brave in sharing all this, with me right now. And, we kind of say that, someone might be in physical pain and we create a treatment plan for them. And we want to do the same for your emotional pain too. So I'm going to be asking a few more questions to help understand this pain better.
Okay.
Okay, so about the Benadryl, can you tell me when exactly this happened?
Well, it was before Christmas when I was feeling really overwhelmed.
Okay. Um, and that must have been a really hard time. Can you help me understand what led up to that moment?
I was, I mean, my ex texted me and said she doesn't want to see me again. She then just ghosted me. We had a fight a few weeks ago, but I don't know what else was going on with her. I haven't heard from her. Um, and I texted my grandmom telling her that I loved her, and then I took the Benadryl.
Um, how did you feel afterwards?
To be honest, I woke up feeling really sick and just feeling worse the next day. I was late to school, but no one cared. It didn't fix anything, and I feel stupid. I don't know who to talk to. You're actually the first person I've talked about this.
I'm so glad you're telling me and talking to me about this now. I know your grandma is really important to you, so having her support will be super helpful. And another thing that can help is talking with a therapist. Would you, who can you trust and who can that you can trust and can help you work through these things? What do you think about that?
I don't have anyone like that right now, but my friend sees a therapist and he really likes it. Maybe I can try that.
Okay, we are going to figure out how to connect you to a therapist today. But we're going to walk through now some questions about how to create a safety plan so that you know what to do if the suicidal thoughts or feelings come up again. What are some of the warning signs you start to feel when you feel suicidal? Like what happens right before you feel suicidal?
I start to cry a lot. I start to feel alone. I don't want to talk to anyone. I just want to lock myself in the bedroom.
Okay. Um, what or who motivates you to stay alive, to keep going?
I don't know. I don't think maybe my dog and grandma.
Okay. And what are some ways you can cope or things that can do to help you through this moment?
Talk to my best uncle and sometimes maybe my grandmom too, and playing video games.
Okay. And do you have anyone else you call for, any adults in your life or other professionals like at school that or church that you might find supportive that you could talk to?
Um, I don't have any counselors, but there's a teacher at school I like and I do talk to him, so I guess I can talk to him.
Okay, so also in this plan that I'm going to write up and give to you, and your grandma is the suicide hotline numbers to call that you can text or chat at any time, any day. It's confidential and it's an easy number to remember. It's 988. Would you be willing to commit to calling them if you're unable to reach out to your supports?
Yeah, for sure.
Okay, so now we're going to talk through and find out how we can make your home and other places safe. We ask all families, are there any guns or weapons and medications that need to be locked up and removed?
There are no guns. There's some medicines in the cabinet, but you'll have to ask grandma about it.
Okay, and maybe we can start the conversation with your grandma. We're going to talk to her next by sharing about, you know, your feelings that you've been going through and around your thoughts about the medications. So would you want me to ask her and tell her about this, or do you want to share this with her yourself?
Um, can you just tell her? I don't want to tell her about this.
Okay, will do. I'm gonna have your grandma come back and join us. Our grandma, thank you for coming in. I wanted to talk to you about what's been happening for Eileen, and they've shared with me that they've been feeling really sad and overwhelmed and had thoughts about wanting um, to overdose with taking medications like pills or Benadryl. They've actually even started to collect the medications and know where they're kind of located. I know this might be really, really hard to hear, but we're here to talk about it and make sure that she's kept safe, they're kept safe, and that we address this together as a team.
My goodness, I had no idea. What can we do?
Okay, we're right now, this is what we're doing is we're talking about it, and then we're going to safety plan. So one of the first things we do is making sure all medications in your home are locked up and they're not easily accessible. We often recommend using like a lockable toolbox or container that you can get a padlock for, and put in all the medications, your medications, anybody medications in the home, prescription and over-the-counter medications as well. Do you have a lockable container or toolbox or closet at home that you
Yeah,
today?
we don't have one right now, but I can go get one today.
Today, okay. And so right after this, you're able to go and pick one up.
Yeah, it sounds really important. I can do it today.
Okay, thank you. Just double confirming. In addition to medications, it's also important to remove other items that could be dangerous, like sharps, like knives, scissors, razors, safety pins, nails, and needles. Other potentially dangerous items include ropes, extension cords, belts, alcohol, recreational junks, and cleaning products. And I know it sounds like a lot, but it's for, you know, a crisis time right now. And we ask that you go carefully through the home, including the garage, basement, or tool sheds. And we, you know, just secure and lock these things up altogether. And sometimes we ask other family members or other adults to help us go through the room so nothing is missed. I kind of think of it like this, you know, when you had the baby in the home, you would baby proof the home, right? You would lock up the cabinets, you would put covers over the electrical outlets. It's kind of the same idea when someone, especially teenagers who are very impulsive, we also kind of safety proof the house as well. And one of the things we know from science and research is that most suicide attempts actually occur within 10 minutes of a suicidal thought. That quick. So by locking things up and securing things, we reduce risks and create a safer environment.
That makes sense. I hadn't really thought of it that way, but I guess you need a teenage proof of house too.
It's like universal safety precautions for teenagers. I also want to double check. Do you have any firearms in the home?
No, we don't have any guns.
Okay, if that ever changes, it's important to make sure they're stored securely and unloaded and locked up separately from ammunition. We want to minimize all risks, and I have some great resource websites on how to safely secure guns if that does come up. I also want to share another important resource with you is the poison control number in case someone accidentally takes too much medicine or there's an overdose of medications. And the suicide hotline number is 988. Um, I'm going to also check back in with Eileen. Do you currently have any other pills or medications hidden, like in your backpack or room right now?
Not like I hid them, but I have some in my backpack. They're left over.
Okay, let's make sure, Grandma, that we collect and go through the backpack and get those medications. And then, we during this time, we actually want to be extra safe. And I know, Eileen, you've been taking medications. We want to make sure that you're swallowing the medications and not collecting them. So during this time, we're going to ask your grandma to make sure you swallow the medications, and then also to randomly check your room to make sure there's no collection or they were mistakenly left out in some way, just to keep you safe. And I know that can be a real invasion of and feel like that of your privacy. And this is what we ask what we're doing to help keep you safe right now. It's part of our safety planning. Is that
So
something
I'm
you
gonna,
could do, Grandma?
yeah, so I'm gonna be going through her backpack, going through her room, just making sure there's nothing there like meds or anything that, might not get used well.
Okay,
Make
thank
sure
you.
it's just all secured away and safe.
Yes, I know this is a lot for you, but thank you for doing that. We want to make sure we have this way of keeping her safe during this stressful time, painful time for Eileen. And we're going to be setting up a therapy appointment. So I'm going to step out for a moment and check in with our team and our case manager so that we can set you up with a therapy appointment and set you up with follow-up appointments. So I'll be right back. And this is where I leave the room and I go and consult with my consultants. And I get all the safety plan printed out and I bring it back. And ideally, we have a case manager who can sit with Eileen and Grandma, because it's a critical time to actually get therapy. It's if someone is suicidal, this is the time to call and they should be able to make sure that there's a therapist assigned, as quickly as possible. All right. So I come back in and I go over the safety plan with Grandma and Eileen that we've written up as specific as possible as I can with all the lethal means that we talked about specifically. And then I review this by saying, Grandma and Eileen, does this feel like is this something the safety plan can help you right now? Are you able to call 911 if you're feeling suicidal, Eileen?
Yeah, I can.
Okay. And Grandma, does this feel is there anything else or any other questions you have on the safety plan?
No, it's good to have this written out. So I'm sure we're gonna get a copy, right? Like both of us. And
Correct.
yes, I can commit. I can commit to doing my part.
Okay. And then Eileen, I just want to see if you would commit to, calling 988 and then following up with your therapy appointment.
Um, I don't really want to talk to someone on the phone. Is there a different way to reach out to
You
someone?
you can text them or chat with them as well.
Oh, okay. I guess I'll do the online chat.
Okay. And then I'm just going to check back in with you, Eileen, right now. How this was a lot that we went through and a lot that we talked about. How are you feeling right now? Are you feeling suicidal at this time?
No, not suicidal. I'm feeling a little bit better, but also scared, like with all the checking, sweeping my room and the lockbox. So I'm just a little bit afraid of what's gonna happen.
And this is for a set time right now, and we will adjust and keep meeting with you and talking and seeing where we're at. And this is, when someone's in so much emotional pain, we want to make sure we have all the right supports for you. Okay.
Thank you so much. Thank you so much for bringing this to my attention.
All right.
And I,
Well, we'll see
Thank
you in
you.
in 2 days.
Thank
okay,
you.
great.
We're coming back next Monday?
That's correct.
Okay.
Okay,
Thank you.
thank you.
Whew. That
So,
was less than 15 minutes, right?
yeah, so it was about 15 minutes. And thank you all for watching this role play. And I saw that there are some questions coming in. We're just gonna take a minute to review the kind of the points to take away from the AAP blueprint. They really encourage universal suicide screening for anyone who's 12-year-old and up, at least once a year, but not more than once every month. And you can even do it for younger children, younger than 12, but for anyone who's younger than 8, then you don't necessarily use a suicide screener because they may not be able to understand the screening questions. And it's recommended to just do a clinical interview that's similar with the safety assessment. Not all patients who are suicidal are depressed. It's a continuum. People can be suicidal for many other reasons too, even when they're manic, when they have hallucinations, if the hallucinations are telling them to kill themselves. So it's really important to do ASQ separately from PHQ-9. There is also a new template for PHQ-9 that has ASQ integrated. So that may be easier and more clinically practical for your clinic to use. And then not all patients who have suicidal ideation require psychiatric hospitalization. The high-risk patients are actually just a very small fraction of the patients that you see. Most of the patients that we see in our clinic are low risk and moderate risks that do need a lot of routine mental health referral or urgent mental health referral, more frequent follow-ups, and lethal means counseling, safety planning, as well as a lot of the flyers that includes resources and numbers for them to call and to utilize when they're feeling suicidal again. And by doing safety planning, safety assessment, and the suicide screening universally, we're also kind of taking care of our own bias because a lot of times certain type of patient don't necessarily always appear visibly suicidal. And suicide is something that's mostly invisible. So it's really important to ask the question. You can also give the questionnaire for patients to fill out, even though that's not a validated method, but it is better than not asking the questions. And then restricting lethal means is really one very effective method to save lives because teens can act within 10 minutes. So that's really kind of putting up stop sign for their impulsive behaviors and then buying time for them to really think about who else that they can reach out to. And then finally, and probably also the most important thing is to create a clinic procedure, a clinic workflow, because it is really hard and challenging to do it just with yourself. So with the kind of a process being embedded in the clinic with everyone, every stakeholder in the clinic being educated and have regular training and everyone knowing what to do if a crisis happens, also determines based on the different risk levels. Everyone will have a different role for different risk level of risk of patients, who to call 911, who to call mobile crisis team if the patient is identified as being at high risk. It will really save you a lot of time during the patient appointment and making everything more smoothly for you, for the clinic, as well as for the patient and their families. And then finally, CalMav is with you for non-urgent consults. We always try to call back within a few minutes to within 15 minutes or so. So please don't call us if it's an emergent case, but we're more than happy to talk you through the patient situation for a more complicated case, even before your appointment with them or right after your appointment if the patient is still in the waiting area being monitored by someone and you're thinking about whether this patient is moderate risk or on the verge of moderate and high, can I let them go? You can call us and we can talk it through.
And what I wanted to say in doing this in this presentation with Dr. Eileen is that why did we emphasize the importance of the clinic workflow and start with that is because we've gotten consults. We've talked to other providers who have had challenges in implementing this. And so having those setups of flags of being able to check back in with the patient that was suicidal. How do you set that up with the patient reminder in your Apex or Epic? And then really, how do we make sure there's a team-based care in supporting you and you have all the right resources and referrals ready in place if this were to happen? Because it's hard when you're in the moment of what we call like a code, basically. You want to have all of that outlined, and you want to have a way that you check back in with your team to what do we need to modify to keep having these codes run more smoothly. We do it even in our outpatient psychiatry clinic. Every time we have one, we reevaluate it in our team meetings. So that was kind of the reasoning we presented this in this way, by actually kind of role modeling it out. We do this with a lot of the residents as well, and they're like, "Oh my gosh, when I hear you do it now, Shelly, I feel more confident in asking those questions and being really straightforward, direct. And I didn't even realize how detailed you get in your lethal means restrictions." And this comes from, and why we presented it, is because I've had the situation happen. I thought I said, lock up all the meds, but the parents didn't hear, "Oh, that means my meds too." And, there was an overdose of the parents' meds and not the kids' meds. And they ran into the parents' room and got it. So a lot of this comes from, as we continue to build out this presentation, how to be as supportive as we can.
Before we
Wonderful.
dive into Q&A, oh, sorry. I wonder if Shelly, do you think that we should go into this, or should we stick with the Q&A?
Let's stick with the Q&A.
Okay.
If there's time after we go through some of these questions, then maybe we can come back to some of these slides. So this is partially answered, but I think it's worth saying out loud. Do you recommend adding the ASQ questions every time a patient completes a PHQ-9, or only when the PHQ-9 is positive? I think the answer came loud and clear. This just needs to happen at least once a year with well child visits, but can you comment a little bit more about this PHQ-9 ASQ form?
Yeah, we will ideally treat PHQ-9 and ASQ separately. So like Joanne, you mentioned, the ASQ will be done every time at the annual well check, but also being done whenever you feel that the patient is having increasing emotional or behavioral outbursts. And you shouldn't use it more than once a month, because if the patient just reported increased emotional or suicidality within the month, then you will do a repeat kind of just update on the safety assessment and also an update on the safety plan. So that's actually a really great question, because that is kind of a pitfall that you wouldn't necessarily think about it unless you have a patient like that who's chronically suicidal. Then you will basically kind of look at the last note and update and revise, confirming with patient that the elements on safety plan is still up to date.
And also the idea is that if someone can feel suicidal and they're not depressed, so how do you screen for that? And by having both of them, the depression and the ASQ, you get around that concern at well child visits.
Great. Thank you for clarifying that. Now, would you recommend doing that ASQ verbally, written, or both?
I think it depends on your team that you have in your clinic workflow. My one thing to the medical providers is, if you have the workflow and if the ASQ you didn't get it, I think you should ask the question, and then see if you need to do more.
When ASQ was first developed, they validated it with having the ASQ being done by the MA directly with the teen. So that was how it was validated. But there are more and more research trying to validate also just for the teen to self-report it on a printed questionnaire and just have the MA kind of obtain it and then record it or report it to the providers. So that potentially can be equally or not by too much inferior to the current recommendations.
And then the safety planning and the brief suicide safety assessment, that's all done out loud together. This is not something that you would just kind of write out. Okay, great. I want to call attention to the QR code on the screen for those who have to get going. Go ahead and use this, or the link that's in the chat to go ahead and check in for today's activity and to claim credit. I don't see more questions right now, so I think this is a good time to go ahead and go back to some of the other slides that you had. So I'll hand this back to you.
So we just added some of these slides to talk about the 5585 process. Because one of the things, as if you're in an outpatient clinic, you're not writing the 5585, and the 5585 is for 12 and younger, as the 5150 is called. What you're writing is a transport hold to have them go to a designated facility to be evaluated if they need a 5585, which is a 72-hour hold. And so I think it's also nice to be able to have the language to talk about it with the family and the young person if you are calling in a unit to do further evaluation. And so we put some language in these slides for talking about the 5585 process. It's a 72-hour hold to see if additional supports are needed, like a psychiatric hospitalization, or you can be safety plan homed. And then the next slide is the designated facilities that can do these evaluations. One is an emergency room, right? And then the others, there are some counties that have crisis stabilizations units that are open to certain, maybe insurances some of the time, and then also by certain age groups. And that the crisis stabilization units are specialized mental health facilities. So you're not in a busy emergency room, but the emergency rooms are important because in case there's any medical concern or issue, you should start there. If there was an overdose or any kind of cutting or something, you would want to go to the emergency room versus the CSU. But there's different ones by different age groups. And then the 5250 hold is a psychiatric hospitalization. So let's say that, you're not going to be safety plan home after the 5585. You're going to actually go to a psychiatric hospital to receive more support and treatment. So that's a 14 more day hold. It doesn't mean someone will stay there for 14 hours, but this is like some language to provide the families of the process if this is what happens next. And around medications and discharge planning the key emphasis is that after psychiatric hospitalization, you should get follow-up care. And sometimes the primary care providers are the follow-up care. But the other thing is that some insurance do provide more step-down care, like commercial does partial hospitalizations or intensive outpatient treatments. And often for Medi-Cal, it's intensive care coordination or RAP services.
Yeah, and then all of these information is not meant for you to kind of memorize because this is not your job to decide whether the patient will need a 5585 or even 5250 hold. But a lot of PCP do reach out to us and wonder about what happens to my patient after they leave my clinic. So, and sometimes patients and families do ask those questions when they're getting safety assessment. So it may be helpful for you to know a little bit of what it may look like after the patient leaves your clinic, when they get to the ED or get to the CSU, how long would they stay there for, and what do they expect from there? And then really the short answer is a mental health professional, often a social worker, sometimes a medical provider, someone is trained in writing a hold, would assess the patient and determine whether they need to go to inpatient psychiatric hospitalization. And then a final part is really ideally after hospitalization, I know a lot of you would get these patients who are getting discharged and then they just got discharged directly back to outpatient clinic. Really ideally, they should have a discharge planning that's collaborated with PCP or with their mental health professional, treatment therapist or psychiatrist. And then sometimes for more severe patients, there is also PHP, partial hospitalization, or IOP, intensive outpatient treatment, that can be an alternative option before a patient get directly home, because sometimes the patient need a few more weeks to destabilize, to further stabilize, even though they're not as acute anymore. They're no longer acutely suicidal, but they're still either hearing voices or still fairly depressed and then feeling really withdrawn and lack of motivation. For patients who have county insurance, they can also be enrolled to a longer-term intensive care coordination program. In some places, it's called wraparound or WRAP.
Great, thank you for adding those details. Let's go ahead and put up this CME QR code again for those who didn't catch it the first time. So that's there. I'm also throwing in the link into the chat. Here, the suggestion came out to, can we turn the ASQ or the brief suicide safety assessment into dot phrases? I personally just cut and pasted text and created my own ASQ dot phrase, and it made it a lot easier to just like pull it up and use it in the moment. I also just typed in my the text for the Brown and Stanley safety plan and created a dot phrase around that I've used in after visit summaries. It took a little extra work to do it, but it definitely made it a lot more accessible. But these resources are on our website. You can use them to hopefully create your own version, depending on the capability of your computer to be able to cut and paste directly into like a text document, hopefully. So it doesn't take too much extra work there. Thank you so much for all of you for coming to our webinar today. Thank you to our great speakers today, Shelly Nakaishi and Eileen Wang, for this talk. We hope that you can come back next time for our next webinar. That will be happening in 2 weeks, and so stay tuned for more. Meanwhile, I hope everyone is doing well, and thank you for all the great work that you do.